Hello everyone, I'm Guduru. I'm going to do a case study on the Chopard amputation, which is a great alternative for non-ambulatory patients. So we have a patient, CP, 74-year-old male. He has a past medical history of frontotemporal dementia, congestive heart failure, hypertension, hyperlipidemia, diabetes, chronic kidney disease, as well as a HFpEF with an ejection fraction of 69%, chronic AFib on Eliquis, severe pulmonary hypertension, very poor compliance with medication, and presented to the ED with a gangrenous left foot. The patient was given IV vancomycin ceftriaxone by their outpatient primary doctor, and the history was primarily obtained through the doctor because the patient was ANO times O, was brought in by emergency services from his nursing home. So unfortunately, we don't have much further past medical history or surgical history beyond that, and we're not able to confirm any known allergies, but he was on a plethora of home medications, and when he came in, his vitals were febrile to 100.5, heart rate elevated to 103, elevated blood pressures, as well as elevated respiratory rate of 24 with 96% saturation on room air. On physical exam, the patient was altered due to the dementia ANO times 0 on baseline. Surprisingly, he had very palpable pulses, 2 out of 4 bilaterally for both the DP and the PT, with diffuse edema to that foot, right to the left foot. On exam, he did have diffuse gangrenous changes to that foot, a lot of purulent dishwater drainage coming from the dorsolateral aspect of the forefoot, a necrotic second digit, white fifth digit, cyanotic third and fourth, very positive for malodor, probe to bone, as well as tunneling along the lateral dorsal aspect of the foot towards the cuboid and a plantar tunnel towards the plantar foot. We weren't really able to assess the neuro and muscular status due to his dementia. So these are the clinical images. As you can see, there's diffuse gangrenous changes as well as that cyanotic and white toe. On X-ray, we were able to see the soft tissue emphysema tracking dorsally and especially plantarly along the plantar aspect of the fifth met towards the cuboid and the midfoot. And you will also see there's a small pocket of gas at the posterior aspect towards the heel. For brevity's sake, I didn't include the tib fib X-rays, but there were no soft tissue emphysema going beyond the ankle. We did console vascular in the emergency room. They did have palpable pulses. They didn't feel any emergent endovascular intervention was necessary at the time, and they agreed with us that either they needed a TMA, Lisfranc, or a Chopard's amputation, and they stayed on board in case there was a need for any kind of BKA. The patient did undergo an emergent Chopard amputation due to the fact of the gas bubbles we saw at the posterior calcaneus, as well as the track posteriorly tracking towards the cuboid. We also ended up pulsovacing. We got dirty cultures as well as clean margins and packed the foot open. We started IV antibiotics and vancomycin, included negative pressure wound vac therapy after the amputation, and followed up any vascular recommendations following. So these are some intraoperative pictures. Clean Chopard's amputation. We found that the navicular bone was viable, hard, healthy bone. So we left it primarily intact with planing to allow for granulation in the future. The X-ray tech took an interesting AP, but you can see that majority of the foot is there, and then we have most of the navicular still intact. So the clean OR margins did show that the patient was growing Morganella morgani, and per ID, they were placed on a 7-day course of vanc and flagyl for the soft tissue infection. And this was found by Morganella morgani, Enterococcus raffinosis, strep anginosus, and mixed anaerobic from the clean OR swab. And they were put on IV cefepime for the bone infection for 6 weeks. We continued them on a wound vac, changing them Monday, Wednesdays, and Fridays with black granule form at 125 millimeters mercury on continuous flow. This is our postoperative day 4. You can see healthy granulation tissue. There's still some seropurulent drainage that we're still continuing on the wound vac. Unfortunately, we did lose the patient to follow-up after we got them to SAR, along with 6 weeks IV antibiotics. Ideally, I would have liked to see continued wound vac therapy, close follow-up, granulation over the exposed bone, as well as completing the antibiotic therapy, and ideally get a graft over that defect. So just briefly, the Chopard amputation was described by Francois Chopard in 1792 to treat infection or crushing injuries. Sir James Symes thought of it as the most valuable of all partial foot amputations, available to remove the largest part of the foot required, to remove disease or injury, but also preserve support for the patient. So in this article, it was a systematic review of the 5-year mortality rate following lower extremity amputations. They looked at 31 different studies showing that the average mortality rate across 5 years can range anywhere from 53 to 100% for lower extremity amputations, with the BKA mortality rate ranging from 40 to 80%, and at the level of the AKA can increase to as high as 90%. A lot of the risk factors include diabetes, peripheral vascular disease, renal disease, any kind of proximal amputation, and age, but surprisingly the most significant were renal disease and age, finding that a lot of diabetics over the age of 65 had a higher incidence of mortality versus those who were younger than that. And a lot of patients with chronic kidney disease and end-stage renal disease seem to have a higher mortality rate after amputation as well. Another review that I found very interesting was the factors that were associated with show parts amputations in patients with diabetes. Majority of the BKAs will occur in an ambulatory diabetic patient, in which a show part amputation could have been a viable alternative. With a show part amputation, you can preserve limb length, you can decrease the energy expenditure, cardiac demand, and also decrease the mortality rate. And they found that this amputation can be maintained for at least 12 or more months postoperatively, with an average follow-up of at least 20 months. And combined with the proper prostheses for ambulation, it can be a very viable amputation versus a BKA. And a lot of the postoperative complications that dissuaded this amputation in the past, such as distal ulceration due to equinovarus contracture, or because of difficulty with shoeing the patient or finding proper prostheses, can be remedied with just getting a proper custom-fitted prosthetic, close follow-up, and wound care. And just linking this all back to the vascular aspect is that while endovascular therapy alone can help treat a lot of diabetic infections, it's not enough to facilitate healing in chronic severe wounds, especially in infected wounds that have ongoing bacterial infections. This article looked at 79 limbs amongst 73 patients that were treated with simultaneous endovascular recanalization of an infrapopliteal lesions and forefoot amputations. The results showed that 42 patients underwent single or multiple digit amps, 22 had TMAs, 11 had Lisfrancks, and 4 had show parts amputations. And they saw that 82% of the patients had a cumulative healing within 6 months, and that the median wound healing time was 76 days, whereas previous studies found that anywhere between 40 to 82% healing within 1 year, with healing days of 92 to over 100 days. These are my sources, and thank you for having me.